Ahmed, thanks for taking the time to have a chat about the IOTA-4 study. You were telling us about the fact that you're all aware of the IOTA models, which are, hopefully anyway, going to help people characterise ovarian pathology. But one of the criticisms, of course, has been that it's been developed by people who, I suppose one would like to believe, at least are experts. So what are you doing with the IOTA-4 study that's different to what we've been doing in IOTA previously?
Actually, it is about what we do in reality, in daily practice. That, as we all know, that the ultrasound scans usually are done by what we call them level 2 experience, according to the Royal College of Radiologists classification. So level 2 are not experts by definition; they are not consultant. So we wanted to see if we exclude the consultant experts from the assessing all the models, do we get the same results? And actually the results were really impressive, and we did get very close results with the models when we assessed the different models in the hands of less experienced doctors.
Okay, so we're talking about
examiners.
I mean, I think everyone knows now that subjective impression by someone who's got experience, and it doesn't have to be a doctor, it could be a sonographer or whatever.
That's correct.
If they're used to actually giving a diagnosis, I think we all accept that's probably the best approach to categorising a mass, but of course not everyone has the chance to scan thousands and thousands of ovaries. Yeah. Can you just say what exactly is LR2? I mean, I know it's a mathematical model. What are we talking about? What do you actually have to measure?
Yes.
To put in, if you like, into the equation to get the answer?
LR2 is a simplified model from LR1. It includes 6 variables, 5 ultrasound scan variables, and 1 is age. The ultrasound scan variables, we look at the evidence of solid parts. We look at the size or the largest diameter of that solid part. We look at the ascites, if there is ascites, yes or no. We look at the vascularized population or population with vascularity, and we look at the irregularity of the internal walls of the cysts. So then we put it in an equation or a formula, which this formula has been developed by another department, which is engineering department in the original publication.
Well, and then you get a risk.
And then we get a risk figure.
So it's not cancer, non-cancer, it just says...
Exactly, it gives a number, yes.
Okay, so when you're looking at the RMI, for example, you use a cut-off of, say, 200. That
yes.
says that defines cancer, so it's actually not telling you a percentage risk which you can...
Absolutely, it doesn't, yeah, absolutely. But this one, it does tell a percentage risk.
But people always like the RMI, don't they? Because it's got CO125, they can measure it and they're comfortable with it. If you look at these variables for LR2, I think most of them people would be happy with. Yeah. But it's kind of looking for blood flow in a pathylation. Is that very difficult, or do you think most people should be able to do that?
I think this has been standardized very well in the IOTA publications, that we need a 0.6 PRF in the color score, or in the color Doppler when we are doing a vaginal scan, and 0.3 in the power Doppler. And actually, the height of the diameter has been explained to be 3 millimeters or more, or at least 3 millimeters. So it's not a problem. It is that there would be no argument about it.
So you think it's something we'd expect any sonologist
to do? Yeah.
Okay. And RMI, I mean, what's your feeling about RMI? I always find it strange, because when you look at RMI, it's actually a mathematical model, and it has ultrasound variables, and I think it's got almost as many ultrasound variables as the LR2, actually.
Yes.
5, I think?
5, I think, yeah. 5, yeah, they are 5. The good thing about RMI, it's simpler equation. However, the parameters we found in our hands of less experienced examiners, that 2 parameters were really quite difficult to quantify.
Well, one will be metastasis.
One of them is metastasis. It's really difficult.
But no one looks for it. Come on. I mean, who actually have you seen who does an RMI, does an abdominal scan, looks for the nose and the celiac plexus? I don't think so. I think it's to do with the CO125, because it's so heavily weighted, the CO125, that frankly I think that's pretty much all the RMI is doing. I don't know what you think.
I'm not sure.
Menopausal status, RMI? What?
It's age again. Yeah. It's more accurate to be age rather than menopausal status, and I think the age factor in the LR2 is much better than menopausal status, could be a figure of 1 or 3, because we're not really, the risk of cancer is not 3 times more in the postmenopausal compared to the premenopausal.
So moving on to the study, you've looked at not a huge number, but about 250 odd masses. Is that what difference did you find in terms of the test performance between RMI and LR2?
LR2 performs much better and significantly better than the RMI.
Across all the patients?
Across all the patients, and this effect was actually magnified or more emphasized in the premenopausal group. It is true that in the postmenopausal group there was no significant difference. That could be justified by the smaller numbers of the postmenopausal group. However, we did not observe RMI to be any better than the LR2. What was interesting as well, the other models, we assessed the simple rules, and we found the simple rules to act very well.
I'll stop you there. Simple rules.
Yeah.
This is another algorithm that's been developed by IOSA. Just if people aren't familiar with the simple rules, I think we've discussed already having logistic regression models and so forth, but the simple rules are a simple kick box approach.
Yeah.
Where there are
10 kick boxes. Yeah.
5 simple rules which indicate that something might be benign, and they're called B rules.
Yeah.
So if you've got one or more B rules, it's a benign mass, as long as there are no malignant rules, or conversely, 1 or 2 malignant rules in the absence of benign rules.
That's correct.
And I think the general view is it will probably be about 80% of masses you can
categorise. This is what we had.
Yeah, so that's what you had.
Yeah.
And 20% which the rules don't apply. Is that the experience in the Alpha-4 trial?
This is what we had actually. We had more than 80%, just more about, I think, 83% that we could classify by the simple rules. And the rest we could not, so the simple rules were not applicable.
And how do simple rules work when you compare it to the data? Because we have the validation, external validation simple rules paper, and you have the BMJ and the White Journal.
Yes.
How did the rules?
Very comparable. I think we have a very good diagnostic odds ratios. I think I remember the number 111, which was very interesting. This is with simple rules plus subjective impression on the portion which we couldn't apply the rules, and this is in the hands of less experience. Actually, in DOR, that was the best achievement of all the models.
Okay, but when you have simple rules, when you have this group of, I don't think less experienced, because they can be quite experienced. They might just have been trained differently.
Yes.
What do you do with the masses, or what do you think we should be doing with the masses where simple rules don't apply?
I think
20%, if you like.
Ideally, the best practice is to send this portion or this percentage of patients to an expert to give an opinion.
Okay. Other ways you can deal with them, because let's say there's no expert in your region. Is there some other way you can?
We can apply a second stage test. We think of maybe LR2.
But if they're all if they're this difficult group, is it not likely that there are going to be quite a lot of cancers there? So I want to just say they're all cancer.
We can do that. That's the other model we assessed. Actually, that's a very good question. We assessed another model where we assumed the rest of where the simple rules were not applicable. We assumed that they were malignant, and we call it SR plus MA. And actually, we still found a very good sensitivity. The specificity has come down a bit, but in total, the performance was still better than the RMI.
Okay, so you can, even if you don't have somebody who reckons they're fantastic,
if you consider them as malignant,
and still overall test performance, you can actually mean it will be pretty reasonable.
Yes.
Okay, so one of the things when people were looking at, the whole point, in fact, of the ultrasound trial to some extent was to say, to help people, you may find that you can get a better diagnosis with these models. Did you find any difference between doctors or sonographers or different types of people? In broad terms, it's small numbers, but are there any indications that people may be performing slightly differently? We
did find a difference. We assessed the level of series in many levels, but in the end we found a difference between doctors and sonographers. We found these are the only two groups. There was a difference.
What were the differences?
Subject impression for doctors was better than subject impression for sonographers.
Okay, so basically doctors were better at saying, I think it's a dermoid, or I think it's cancer, or not.
Exactly.
And how did they perform with models?
We didn't find differences in the AUCs between the different models, whether we say doctors or sonographers.
So what we're saying is they can see the things, they're just not being trained so much to give an opinion, perhaps.
I think if they have to, exactly, this is what happened. They have different pathway of training. Maybe if they have the same opportunity like doctors to have feedback or histology or surgery, maybe subject impression can become close to the subject impression of doctors.
Yeah, I think it's important so this is not saying anything about sonographers. I think sonographers, this is why I tend to sort of shy away from this concept of experienced operators, because of course there are some exceptional and very experienced sonographers, but I think sometimes my personal experience has been they've perhaps been reticent to put their neck on the block and say cancer, non-cancer, and rather just describe the mass. It's a multicystic mass with solid area, and then leave it to the clinician to decide that's cancer. Whereas I think we're perhaps a little bit more likely to be bullish about it and say, I think it's cancer, I think it's a dermoid. I mean, that's basically how it seems to be.
Yes.
So I think the hope would be we get more meaningful reports if we use LR2 or something like that.
I think so. I think we should.
Okay, so if we sort of summarise where we are, obviously the main IOTA studies produced LR1, LR2, the simple rules and so on.
Yeah.
And I think what the provisional or the data from your study is suggesting is that these models and rules work as well in a sort of range of real-world scenarios, I think. Is that fair to say?
Correct. That's correct.
And would support the Royal College's recent change in guidance in premenopausal women, certainly that we should be using simple rules.
That's correct.
We could also use LR2.
Yes.
And there would be no reason not to use it in postmenopausal women, which would seem more rational to me.
Absolutely.
Slightly better.
Absolutely.
So is that the direction you think that people should go in?
I think this is the direction we should go for. I don't understand why CA125 was chosen to be put in a formula. There are other biomarkers in the market, and there is the yearly biomarker. And the other thing
I've not seen a new biomarker which has been useful. I mean, if you look at HG4, which is the new marker, actually it doesn't add very much to CA125, and we've seen data now from the Dutch group where they've shown the AUCs are actually no better with or without HG4, and CA125 is actually the best of them. So I don't really think there's any logic to using that. And I guess the concern to me is that if you look at NICE guidance, where they're using CA125 as a screening mechanism effectively as a gateway to get a scan, and the same with ACOG, where I think they're using over1, neither of these approaches, it seems to me, make a great deal of sense.
We did assess the CA125 on its own, actually, in the study, and we found it to be performing very poorly. That's why I would comment on it as one parameter to characterize ovarian masses. And we used two different thresholds, 65 in premenopausal and 30 in postmenopausal. We still found it not accurate.
Well, I suppose, I mean, the problem is, of course, if we're moving on to talking about tumour markers, is that people do measure them. And you get this problem of someone coming along who's had an ad hoc measurement of a CA125 level, and then what do you do with it? I mean, especially if someone's like 40 years old and they have a CA125 of 55, and they turn up because their primary care physician is concerned. Well, I mean, your answer is, well, I wish you hadn't had it. But, I mean, it does create problems.
It does create a problem to everybody, to the patient and the doctors.
Yeah, well, I guess we have to watch this space. So I think what we would hope is that, we'll extend these numbers and we'll see what happens with bigger numbers in terms of different centres and different types of user.
Yeah, that'll be the next step forward. Yeah.
But it's pretty reassuring to see that we're getting similar results to the main IOTA group, really.
Yeah, it's very reassuring. I totally agree.
Ahmed, thanks for your time.
Thank you. Thank you very much.